Friends, this film is for training and education of eye surgeons all over the world. Let us learn together. This is a cataract with grade 2 nuclear sclerosis, soft cataract. In such cases, we find difficulty in holding the nuclear mass with vacuum. In such cases, it is always better to divide the nucleus into pieces before entering into the anterior chamber with the Phaco needle. By this time, the main incision has been made and viscoelastic substance has been injected into the anterior chamber and applied over the corneal epithelium. This is a side port on the left side of the main incision, about 90 degrees away from the main incision. Now, capsulorhexis is done with the help of a utreta forceps. Dear colleagues, this is a totally unedited surgery and you are not missing anything. Totally unedited and real speed. Capsulorhexis has been done with the help of a utreta forceps. Now, BSS has been taken in a 2 cc syringe and a 27 gauge cannula has been attached at the tip of the 2 cc syringe. Hydrodissection is done and now the nucleus is rotated. Viscoelastic substance is again injected. Now I am going to divide the nucleus into several pieces before entering into the eye with the Phaco handpiece. This is a pre-chopper. This can be carved, this can be straight. The front edge is cutting, the back edge is blunt. The back edge which may touch the rhexis margin is blunt. The tip length is about 1.5 to 1.7 millimeter. The sustainer is of same tip length and both the instruments are removed. If you want to learn this pre-chopping, you have to go through several videos of mine. Just type my name and then pre-chopper and you will find many videos. Some videos will be in slow motion to teach the use of pre-chopping in soft cataracts. Now, this is on heminucleus. It is pierced at the middle and it is easily divided into 2 pieces by the sustainer. The ball-tipped chopper is also called sustainer. The ball-tipped chopper is also called Neto chopper because Dr. Neto Rosatelli of Brazil uses similar kind of chopper, but he uses a longer one and this is only 1.5 millimeter. And now cortical cleanup is to be done. You can use any method to clean cortex, coaxial IA, bimanual IA, Simco, whatever. Just do a nice job. Clean the cortex nicely. There should not be any lens fiber sticking to the posterior capsule. I find this instrument very gentle and very safe and it works well in my hands and it is attached to a separate bottle. The assistant can give this instrument to me immediately. He does not have to detach the irrigation aspiration cannulae of the Phaco machine, tubing set of the Phaco and get ready in about 20-30 seconds. This Simco is ready in a separate bottle. Okay, cortical cleanup is done and now is the time to implant an intraocular lens. Before that, this is hydro polish. The irrigating jet of bimanual IA, the sister has got enough time to get ready with the bimanual irrigation aspiration by this time and cortical and the posterior capsule is being polished just by the irrigating cannula. The aspirating cannula is not being used. I have encountered postcapsular rinse during cap back mode of intraocular postcapsular polishing. So I have given off that and clean the posterior capsule just by the irrigating probe. And this is hydroimplantation of a single piece monofocal aspheric intraocular lens. No fancy intraocular lens, very simple one, and the many patients of the Indian subcontinent is happy with this. They don't mind using glasses for near. This will give very good distance vision. The side port has been closed, and I'm going to do a final lavage of the anterior chamber. At this time, a gentle stream of BSS is directed towards the corneal endothelium, and any visco sticking to the corneal endothelium is removed. The anterior chamber has been nicely formed. Integrity of all the wounds are checked. Few drops of moxie is applied over the cornea. And now we are going to conclude the case. I find that the antechamber is soft, eyeball is soft, so I form the antechamber again. Now I check again if the wounds are okay or not, if there is any wound leak is there or not. Let us see. Yes, there is some wound leak, and I am hydrating the main wound. Usually this doesn't happen in my surgeries, but sometime it may be required to hydrate the main wound. And now I form the antechamber again, and this time the intraocular pressure appears okay. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.